alerts about what's coming up. So hopefully hopefully you guys have been joining, and if not, hello to all of our first time viewers. We have a ton of videos available for you guys on demand on Facebook and YouTube, so make sure you check those out. But again, today we're going to be talking about Parkinson's disease, and then on Thursday, again, same time, same place, we're going to be talking about Alzheimer's disease. So a little bit of Parkinson's, a little bit of Alzheimer's this week. Two really important disease processes and a lot of teaching behind those, especially around safety. So today we're going to go through kind of like how we always do with some of these disease processes. We're going to talk patho, treatment, nursing interventions, and then again client and caregiver teaching, which are really important with Parkinson's disease. We have a question that we're going to do as well. And then as we go along, make sure you ask some questions in the chat. We have our experts here monitoring that chat that can help respond to anything you might have, any questions you have about UWorld, any questions you have about the content we're talking about. So don't be afraid to chatter along with us. We love to see what you guys have to say, and if, as always, let us know if there's anything you're really interested in learning about, and we will be sure and put that on our list and get our content ready for it. So we are going to start off, as we usually do, with a question. So we're going to bring up a question slide for you guys, and we're not going to answer this right away. We're going to go through our content and then answer it again at the end, but just something to kind of keep our wheels spinning and help us think about the content as we go. All right, so question says, which of the following interventions, I missed the most important part. The nurse is planning care for a client with Parkinson's disease. So again, the topic of our conversation today. Which of the following interventions should the nurse include in the client's plan of care? Select all that apply. So again, this question is focused on a plan of care. So that's really where us as a nurse, we have to understand what's happening with the disease process and kind of know those interventions that are going to be safe and important for our client. So those are going to be our option choices that we're going to look at. And then select all that apply. Don't be afraid of it. We're going to approach it like we always do with a true-false approach. So again, select all that apply indicates that we're going to have more than one right answer. So option 1, discourage the client from consuming snacks between meals. Option 2, remind the client to move slowly when transitioning from a sitting to standing position. Option 3, instruct the client's spouse to remove throw rugs from the home. Option 4, teach the client to use visualization techniques when experiencing freezing episodes. Option 5, encourage the client to take carbidopa-levodopa with high protein meals. All right, so that's what we're going to be kind of talking about, all these different things that we might see in a plan of care, but we're going to start off with some patho. So we'll kick it off that way and kind of get a little bit more understanding. And again, the whole point of us talking about the patho of these disease processes is really just to kind of build a foundation for you guys so that you can think critically around these questions and not feel like you're memorizing stuff, but really kind of give you the basics that help you answer these questions. And knowing how things are working in our body is going to help us be able to answer these questions easier. And then again, we're going to help you give you that extra boost with some test taking strategies too. So we're going to combine it all together. Okay, so let's talk about Parkinson's disease. So Parkinson's is a progressive neuromuscular disorder. So this is really going to clue us into our manifestations. So we're going to think about how stimulus from our brain impacts muscle activity, especially our smooth muscles. And you can also think Parkinson's progressive. So that really means it's non-reversible. It's going to continue taking course as time goes on. So in Parkinson's, we have two primary neurons that are affected, or neurotransmitters. Those are dopamine and acetylcholine. So with dopamine, we have a degeneration or a breakdown in Parkinson's. So as a refresher, dopamine typically is kind of slows and calms us down. So you can think like D-dopamine down. The opposite is true with acetylcholine. So acetylcholine is an excitatory neurotransmitter. So this imbalance can lead to protein formation in our brain called Lewy bodies. And this imbalance is really what leads to that and leads to a lot of those muscular manifestations. So knowing this patho, we're going to put it all together and see how Parkinson's presents in our clients. So we have a really great image to show you guys. This is an image of kind of the typical manifestations of a Parkinson's client. And this is just an example of like the really great imagery that we have here at eWorld. We have an amazing team of illustrators that really show all of these disease processes and really intricate things, show them in visual form. So anyways, okay. So for Parkinson's, a helpful mnemonic is TRAP, so T-R-A-P. And as we go through this, you can kind of think about how the breakdown of the neurotransmitters that kind of keep us calm and coordinated, and then the overproduction of the neurotransmitters that make us like excitable, how this can kind of result in these manifestations. So T in TRAP stands for tremor, specifically at rest. So a lot of times it looks like this, kind of like a hand tremor like this. I hope you can see my hand, like this. And then it can also be like a pill rolling tremor. So just think if you had like a little pill in between your fingers and you were rolling it back and forth. That's what a pill rolling tremor is. And again, this happens typically in our hands. We also will have, so that's T, tremor. R is for rigidity of muscles. So we become twitchy in this imbalance of dopamine and acetylcholine. So when we think about muscle rigidity, think stiff. So just kind of think real stiff, not relaxed looking. A is akinesia or bradykinesia. So clients with Parkinson's often have a shuffling gait and experience freezing episodes. So that's that akinesia part, kind of lack of movement. And then bradykinesia is slow movements. So that's T-R-A, and then P is postural instability. So when you see a client with Parkinson's walk, you're going to see a really narrow base and a shuffling gait. So just kind of think like really tiny steps and not a lot of swing happening. So these clients are going to also have like a stooped posture, which can lead to kyphosis, or kind of like that hunched appearance, like kind of hunched over like that. Another telltale sign of the Parkinson's gait is how these clients turn. So not only are they going to, not really move with a smooth gait, but they're not going to be able to rotate easily. So if we were going to turn, walking as someone without Parkinson's, we would likely turn our head before we kind of move our body, just to have a visual field of where we're going, but that's, kind of how we move. We can move independently. But with Parkinson's, they have what's called end block turning, and they're just going to move as a unit. So they're going to just think that they're kind of like operating within a box. So they're going to move like this. So when we kind of put that all together, like the slow, stiff movements and a narrow base and kind of limited visual field, we're really going to tie this into safety like we talked about last week. And we're going to worry about falls. So we're going to worry about falls because of that shuffle, and we're going to worry about falls because we're not able to kind of turn as much as we would have been able to. When we talked about how the NCLEX is a test designed around safety. That's really what these questions are driving home, is to make sure as a nurse you will have safe practice. So that's a little bit about the manifestations. Again, TRAP, T-R-A-P, tremors, akinesia, rigidity of muscles, and P, postural. Oh, I spelled that wrong. I'm so sorry. That was TARP. I guess that still works. But T, tremor, R, rigidity of muscles, A, akinesia, and P, postural instability. But feel free to, make a different word if you want to. Okay, so talking about diagnosis of Parkinson's, diagnosis is a little bit different since there isn't really one test to diagnose it. Imaging like MRI and CT are typically going to be normal in a client with Parkinson's, but what is they're going to be used for is to rule out other conditions that might be causing these similar manifestations. So things like maybe a tumor or stroke or other things like that. So in order to diagnose Parkinson's, 2 of the 4 TRAP manifestations must be present. Then once 2 of those have been identified or they are present, once treatment is in place, a positive response to anti-Parkinson drugs, which we're going to talk about a little bit later, is what confirms the diagnosis. So kind of knowing what we know, let's talk about complications, and then we're going to immediately talk about teaching for these to kind of just tie it all in. So we've already really talked about the first one, which is falls. So we are going to teach these clients, so again, falls, we worry about falls because of the rigidity of muscles, the shuffling gait, kind of the slow or freezing movements. So again, we're going to teach these clients about basic fall prevention principles. So that looks like things like wearing non-skid socks or shoes when ambulating. So when we're walking, so we're not slipping on anything and we're not sliding. Removing anything from walkways that can be tripped on, like throw rugs or cords. So again, that shuffling, our feet are going to get under stuff and we don't want to fall on anything. And then we're also going to teach them about assistive devices like walkers or canes, and even assistive devices for like our ADLs, like our activities of daily living. So things like raised toilet seat, ensuring there's railings in the bathroom, a shower seat, and different things like that that are going to kind of help us maintain some of that independence. And then clients with Parkinson's can also experience orthostatic hypotension. So their blood pressure is going to drop when they go from a sitting to a standing or like a lying position, or I'm sorry, sitting to standing or lying to sitting to standing. Again, so we talked about how Parkinson's is a neuro and a muscular condition. So again, think about that communication loop between the brain and the heart, and when we change positions, how that can be impacted. So we need to teach these clients to transition slowly from position to position to avoid passing out and falling, again, bringing it back to safety. So again, the P in TRAP is postural instability. So the first thing we also want to do is involve physical therapy. So it's important to really maintain and build muscle strength early on in diagnosis. So in addition to PT, we're going to teach just basic stability principles like arm swinging to these clients. So again, the arm swinging is going to help keep them balanced, but it's also going to help keep them in motion and prevent those freezing episodes. And then if freezing happens, so they literally just kind of stop in motion and can't get things moving again, we're going to teach them visualization techniques so they kind of re-engage that brain-body connection. Okay, so that's a big one. First one, fall prevention is what we're going to teach them, and is specifically orthostatic hypotension teaching and kind of preventing freezing. Okay, so our next one is dysphagia and malnutrition. So again, dysphagia is that difficulty swallowing. So when we talked about falling, we really talked about those big muscles that are impaired, but we also have to worry about our smooth muscles and our smaller muscles. So think of that for everything that's involved with digestion. So we're going to worry again about dysphagia, so difficulty swallowing. So I have a question for you guys, and make sure you use the chat feature. Tell me in the chat, what is a major complication of dysphagia? Again, what is a major complication of dysphagia? And let's see what you guys are saying. Awesome. Cool, cool, cool. Oh, I see you guys have answered the question a little bit already. That's awesome. Very cool. All right. So I'm starting to see some things come in. Very good. Choking for sure. Aspiration. Yes, you guys got it. Aspiration is really what we worry about, specifically aspiration pneumonia. So just like we engage physical therapy for body mechanics, we need to engage speech therapy for dysphagia and then a dietitian for malnutrition. So there's a lot that goes into kind of this impairment of swallowing and how that affects our overall nutrition. So we really need to do a swallow study to see if our client needs to be on any precautions to prevent food and liquid from going from our esophagus into our airway. So Again, this can look like things like thickened liquids or even how to administer nutrition if the condition has progressed to needing like a G-tube where we're administering nutrition outside of the mouth. We also worry about malnutrition for multiple reasons. So it's going to take these clients a lot longer to eat and they are going to fatigue quickly. So meal planning with a dietitian is really essential just to give these clients the fuel they need. So think time. So they're going to need ample time to eat their meals, and they're also going to want to consume more frequent meals. So a lot of time to eat and more meals during the day. We're also going to want to pack these meals with as much energy as we can. So think high calorie, high protein meals. So when we say things like that, you can think like, I might see a question about diet on the NCLEX. So knowing examples of those high protein foods would be helpful to know, and then what distractors you might see. So things that maybe are high in sugar but not high in protein, things like that. So diet questions are commonly seen on the NCLEX, and we know that from our test plan as well. Okay, so let's move on to the next one. So we talked about falls, dysphagia, and kind of subsequent malnutrition. Now we're going to talk about constipation and bladder problems. So in the same vein as dysphagia, another complication is going to be constipation. So just as our smooth muscles for swallowing are impaired, the same smooth muscles for digestion, like in our lower GI tract, are going to be impaired too. Same with our bladder. So Parkinson patients typically experience constipation and problems with urination, both incontinence and difficulty urinating. So we need to teach these clients to increase their fluid intake, which can be very difficult since we already know they're going to have some dysphagia. And we also need to teach them to increase their fiber intake, but we're also telling them to have high protein, high calorie meals. So again, there's a real fine kind of dance that goes on with everything when we're helping care for a Parkinson patient. So just to recap again, make sure we're all on the same page. We've talked about falls, teaching for that, fall prevention. Dysphagia and malnutrition, teaching for that, we're trying to mitigate the risk of aspiration. And then constipation and bladder problems, we're trying to make sure that we're maintaining our GI and GU function. So other complications can include sleep problems and depression and dementia. So Valerie on our team did a really amazing live and learn on the differences between dementia and delirium. So I encourage you guys to go check that out. But again, Parkinson's is a progressive condition. So these changes in our brain are going to occur and they're not going to resolve. So again, it's all about symptom management when we're caring for them. So knowing this in terms of teaching, we need to think how to listen and communicate with these clients. So this can be some of those therapeutic communication questions you might see. So these are questions that kind of aim at helping, making sure you can identify examples of like active listening. So hearing what the client is saying or the caregiver is saying and then being able to repeat that back. Asking open-ended questions. You want to really get as much information out of these clients when you're talking to them as possible. And then asking clarifying questions and reflecting back on what the client is saying. And then again, stating observations to really validate what the clients are talking about and the caregivers. There's a big element with caregivers in Parkinson's, as with Alzheimer's, that we'll talk about on Thursday, but there's a lot of caregiver strain that happens with caring for clients with a progressive condition. Okay, so let's talk about medications and procedures to manage symptoms of Parkinson's. Again, this is a progressive condition, so we're going to work on maintaining function and quality of life as long as we can. So medication management for Parkinson's really focuses on replacing dopamine. So there's several medications that can be used to treat Parkinson's, but we're really just going to focus on the most commonly used ones and the ones that will be given at the onset of symptoms. So one thing to note with these medications in Parkinson's is that over time their efficacy is going to wane. So how these medications work on day 1 is not going to be the same as they work on like year 5. So their body is going to adapt to them and they're going to become less effective. So that's where a lot of these newer kind of combination or different mechanism of action medications are going to come in. But again, we're just going to focus on the basics for today. So some of these medications include carbidopa and levodopa. So these medications, again, are dopamine precursors. So they're going to convert to dopamine in our brain. A really important safety note on these medications is the dopa medications is that they need to be taken on an empty stomach. So meals or foods high in protein can interact with them and decrease the absorption of the medication. So we're not going to get as much function out of the medication as we would on an empty stomach. Other medications are stimulate dopamine receptors. So that is pramipexole and ropinirole. Another one is amantadine, which is a dopamine agonist, and this increases dopamine release. So again, these medications are all addressing dopamine at different different areas of function. Other medications include anticholinergics like benztropine, which are used to help control the tremor. So again, it's all about managing symptoms, improving quality of life. These medications, though, anticholinergics, can have a lot of unwanted side effects. So if you guys haven't learned anticholinergic side effects, there's like a number of mnemonics. But before I share one of these, I'm going to ask a question, ask you guys to kind of answer some of these anticholinergic side effects in the chat. So use that chat function again. Tell me some anticholinergic side effects or side effects that happen when we have too much anticholinergic in our system. And you can also share your favorite mnemonic if you want to. Let's see. Very cool. Yes, dry. That is definitely the key. Okay, so one I learned, I won't say all of it, but I'm sure you can infer what it is, but it's can't see, can't pee, can't spit, and then it relates to constipation. Okay, so for can't see, you're going to have blurred vision, dry eyes, sedation, dizziness, confusion, hallucinations. Can't pee, again, you worry about urinary retention. You're not able to urinate. Can't spit, dry mouth. And then again, the other one that's like not suitable for all audiences here, but constipation. So those are side effects of anticholinergics. So again, it's a fine dance of these medications that are controlling dopamine and also controlling medication side effects. Okay, so surgical procedures include deep brain stimulation and ablation. So these are typically going to be done after these procedures will be done after medications have failed or they're really not as therapeutic as they once were. So deep brain stimulation is essentially a pacemaker for the brain. So an electrode is placed in an area of the brain and it's wired to a generator in our upper chest. And it's programmed to send electrical currents through the electrode. So the objective again is to improve motor function and reduce some of that akinesia or bradykinesia. Another one again is ablation. So we talked about ablation when we talked about AFib, and essentially what happens is the provider will go in and zap that part of the heart that is malfunctioning or it's finicky or causing the problems. So the same is true in Parkinson's, but it's going to be through the brain. So we're going to go in and kind of zap that tissue in our brain that's causing a lot of these motor functions. All right, so again, the goal is to neutralize brain tissue that's causing these tremors and causing other symptoms. All right, so that's Parkinson's for you guys. We're going to bring it back to a question and see, knowing what we know now, how we'll answer this question. So we will go ahead and bring the question back up here in just a second. All right, so the nurse is planning care for a client with Parkinson's disease. We now know all about that. Which of the following interventions should the nurse include in the client's plan of care? So again, we're thinking safe interventions that will help our client. Select all that apply. So we're going to go through this with a true-false approach, and we're going to have more than one right answer. So option 1, discourage the client from consuming snacks between meals. This is not going to be a right answer for us. This is a false statement. We talked about how we want these clients to have small, frequent meals, and we really want to load them up with high protein as well. So we want to encourage them to have snacks in between meals. Option 2, remind the client to move slowly when transitioning from, transitioning from sitting to standing. So this is a true statement. Again, we're talking safety, we're talking fall prevention. So these clients, we talked again, they'll have orthostatic hypotension. So they're going to experience a big drop in their blood pressure when they change positions. That kind of communication between our brain and our heart is going to be delayed, and blood's not going to get where it needs to get to fast enough. So this is a true statement. We want to tell them to do that. Option 3, instruct the client's spouse to remove throw rugs from the home. This is true. We talked about this when we talked about fall prevention also. That shuffling gait and that slow movement and that freezing movement, that can cause falls. And throw rugs are like a culprit of that. Throw rugs and cords, anything that we can trip on. So we're going to ask for those to be removed. And then option 4, teach the client to use visualization techniques when experiencing freezing episodes. So again, this is true. We talked about that akinesia, or that freezing that happens. And when we teach our clients to kind of visualize their foot, moving over a box, it's going to re-engage our brain and muscle connection, and it's going to help them be able to kind of start moving again. We're also going to teach them, swing your arms, got to kind of keep that momentum going. So that's a true option, a correct answer. And then option 5, encourage the client to take carbidopa, levodopa with high protein meals. So again, we talked about this. This is a false statement. We talked about how this medication won't be fully absorbed when it's taken with food, especially protein. So we're going to encourage them to take it on an empty stomach. So it's a false statement. So our correct answers are 2, 3, and 4 for that one. But that's really what we have for Parkinson's today. But I did want to tell you guys, as we always have said in this closing, please remember, go to nursing.uworld.com and check out our 7-day free trial. We have so many amazing resources, and we're just so proud of the work that we do here. We want you guys to all benefit from it, to be successful in nursing school, and most importantly, be successful on your NCLEX. So take a look. It's free. You literally have nothing to lose, but you can see all our amazing questions, our explanations that are really going to provide you with that active learning. You're going to learn why things are right, and you're going to learn why certain things are wrong. You're going to see our illustrations, our video lectures, our animations, so much great stuff. And we also have a ton of case studies, and I feel we really have the best case studies kind of in the business. So take a look at them. There's so many to look at, so many to choose from. But let us know what you guys think. And again, best of luck to you guys. Come back on Thursday, same time, same place. We're going to talk about Alzheimer's, and we hope to see you then. Thanks so much for joining. Bye.